The project that I've chosen to describe here for the final submission of course 2 is to automate the surgical bed balancing process, optimizing the allocation of beds for scheduled surgeries and demand for daily ER cases, specifically looking at hospitals in Ontario, Canada. The first question around opportunity evaluation, yes, yes, there is a problem, and one that has medium to high business impact and is highly feasible. The current process is manual and reactive, resulting in hallway medicine and delays in clearing the elective surgery backlog and limiting the ability to deploy innovative care models. Um, and ML can be used to feasibly solve the problem and be deployed in a meaningful way, either through real time or batching process, depending on the service demands that need to be balanced. All, if not most, of the data should be available through different systems or Excel sheets. Interoperability will be a challenge to overcome, but can be worked around. The goal here would be to predict the availability of beds over a 24 to 72 hour time frame through forecasting, and then uh, maybe even extend the prediction once the model is trained to a week-long outlook, which helps balance the surgery backlog, demand from ER, and better plan clinical shifts. I won't read everything on the slide, but you can see what's on here. In terms of the CRISP-DM business understanding process, the target user is the bed flow manager. Now, the problem and why it matters is really the Ontario hospitals face a daily operational challenge of balancing the limited inpatient beds that they have now between the scheduled elective surgeries, which is the planned demand, and the unpredictable admissions from the emergency room for surgical cases, which is the unplanned demand. And this highly manual and reactive process results in long wait times, hallway medicine, which is really patients without beds, last minute surgery cancellations, ER boarding delays, and inefficient bed utilization. The gaps in the process are really that it's a daily morning huddle, and a lot of it happens through negotiations between department heads and bed flow managers. There's limited use of data or transparency in the decision making across departments. The success here really will be the ability to predict the balance, the allocation of beds, reduce the elective surgery and ER wait times, and improve the resource allocation across the different departments for surgical cases. The constraints here will be inoperable data sets, manual data captures that happen sometimes in Excel sheets, lack of data schema, essentially meaning data being captured slightly differently across different departments, which over the years has been standardized, so this should be less of an issue. And the change in workflows with a ML model will cause some tensions in terms of adoption, and it will be a change process, but taking the users along the journey in the design of the model itself will help with the adoption. Success metrics here would be in terms of outcome, bed allocation effectiveness, reduction in ER wait times for surgical cases, and reduction in surgical backlog. In terms of the output metrics, since this is a continuous variable, you would look at a root mean squared error. Potential relevant factors would be historical surgical data in terms of expected and historical lengths of stay by type of surgery, specialty, the surgeon, because each surgeon will have post surgical care instructions that are different. So, how those are done also affect the length of stay. Staffing levels, the step up, step down needs based on the surgery and the condition of the patient. From the emergency room historical admissions data, the reserve capacity, and also sometimes when it's a flu season or some adverse events happen, you have to predict the surge demand. So using public health data and population census to be able to predict those, and using the historical data lines to be able to predict those needs as the flu seasons and other pieces unfold. In terms of validation plan, the users should be involved pretty much throughout the process. The concept here really is connecting decisions across four key areas. One is predicting surgical bed demand and expected discharges over the next 24 to 72 hours, and then the week-long outlook. Forecasting ER-driven bed demand by day and type of bed. Recommending which elective cases from the wait list can be scheduled, and staffing plans, and flagging any likely bed shortages, which are done more in real time based on how discharges are happening. But the users, as I said, should be involved throughout the process in terms of business understanding, engaging the users to identify the pain points, defining success, the relevant factors, and documenting the current workflow. In terms of data understanding, creating features and understanding relationships and patterns between the features and the target variable, which is the bed allocation. Data preparation, reviewing historical data and how decisions were made regarding bed balancing and allocation. This will help minimize any bias that might exist with the historical data itself. Work with users to define and document new workflows, and this will help with adoption and identify change considerations, which will be part of the adoption plan. In terms of modeling, running a silent pilot in parallel with the manual process, so kind of like an A/B testing to identify and assess the effectiveness of the model early on, and gather user feedback to make any necessary revisions before a controlled operational pilot is held in the evaluation phase. There you use the model as a decision support tool with select surgical departments to evaluate the model, and then make necessary changes based on threshold performance. And work with champion users to deploy the model and gather feedback and monitor it. And in the monitor period, do periodic audits and assess how the redesigned workflows are working, and identify any improvement areas and retraining factors for the model. In terms of the system design, we would recommend a cloud-based architecture to ensure security through the cloud-based infrastructure, especially as it depends on multiple data sources across the hospital, and it will make it easier to monitor and retrain and centralize the governance. We would recommend offline training, as the model involves clinical and operational decision making in a high stakes environment, where you're working with patients and allocating clinical resources. So the model, any retraining or changes to the model will have to be validated before deploying. And the cadence of the retraining should be agreed upon between the users and the ML and data engineers. In terms of batch online predictions, I'd recommend a hybrid because the core processes can be based on batch predictions, with online predictions for some real-time updates, especially with incoming ER cases or any discharges that are done based on how the patient is feeling. In terms of potential risks in production, there is a risk of data drift, so surgical codes and other data captured with different consistency or interpretation across specialties. Length of stay capture with patients who underwent multiple procedures could be a potential data drift as well. In terms of model drift, surge demand during flu seasons or adverse events can cause a model drift. Historical length of stay patterns might change in surgical patterns or post-surgical care processes can change the length of stay. There can also be automation bias, so ineffective human-in-the-loop decision-making or over-trust in the model-generated decisions, resulting in not using the human intervention from the user. There can also be some fairness constraints. The model could deprioritize lower complexity cases, certain specialties or surgeons, higher complexity cases, because the model would want to the bed allocation to work more efficiently. So they would prioritize lower specialty cases. The inherent bias of also previous surgical patients who had or suffered from mental health conditions post-surgery, which caused them to stay in bed longer or be transferred to different beds. That can also cause some fairness concerns because those patients could get deprioritized and would lead to bad clinical decision making and patient outcomes. That brings to the end of the ML based project for course 2.